in AD subjects. And as Dr. Shivkumar mentioned, there are several initiatives of data collection involving MRI and PET, but I will be using mostly MRI, right, based on what we have covered so far. So first, I would like to cover some structural differences, then functional, and then looking at network abnormalities, right? So this is how different resting state network, the location of the networks, and their functions, right? And so you have default mode, which is in the posterior cingulate, precuneus, medial frontal, lateral temporal, and these are associated with task negative, cognitive, and social processing, right? And then we have a series like visual network would be obviously vision, auditory, hearing, and so on. And this is a paper that was recently published by Armindo and Zaharchuk. The title was Clinical Applications of Resting State Network. And this is like they had interviewed, or there was a survey done from 68 clinicians, and where they had rated, right? Like if they rated 1 to 2, then um, like resting state is easy to acquire. So maybe while about half said it's very easy to acquire, maybe 1/3 said not at all. Maybe depending on whether the subject should have their eyes open or eyes closed. Actually, this is what I was very surprised. Oh, never mind. Resting state is difficult to analyze. More than half agreed that, like how we analyze what question to ask. Um, that, but some of the other questions they agreed, right? So the point is there is still some work to be done to make this technique to be useful in clinics, right? So this is one of the earlier paper where they had looked at structural abnormalities, mostly in the gray matter volume between AD versus control, right? Then mild versus AD and moderate versus mild AD, and showing different regions which seems to get affected from the gray matter volume point of view. Basically, it says that in early stages, marked cortical atrophy was detected in the medial temporal and posterior cingulate retrosplenial cortex, together with less pronounced reduction in the orbitofrontal cortex. Also, there was progression from incipient to mild was associated with widespread and marked gray matter loss, affecting broad areas in the lateral temporal cortex, dorsoparietal, and frontal cortex. Then in terms of cortical thickness, in AD, there were subjects with AD displayed decreased cortical thickness in the bilateral parahippocampal gyra, left posterior cingulate gyrus, bilateral orbitofrontal cortex, sensory-motor area, and temporal lobe. Right? And similar changes was also obtained in using ALFF and FALFF. So in terms of functional, this is showing activation for a memory task where subject had to perform. And in this case, they showed that there was an increase in activation in the hippocampus posterior midline, right? And these correlated the change in activation, predicted the change in the plaques, right? This is hippocampal activation, and then this is entorhinal fMRI activation. And then during working memory, they showed that for pattern of increased functional during working memory in ApoE carriers over non-carriers found bilaterally in the lateral occipital cortex and angular gyrus, pattern of increased functional activation, working memory associated with increased PRS detected in the superior frontal gyrus. And then there was overlap between increased functional activation between ApoE carrier and higher PRS, right? So these are for functional. These are some of the earlier resting state activation showing differences between AD and healthy control, showing how default mode is associated with other networks, right? Default mode with visual network and so on. And again, the blue arrow shows decreased resting in patient with MCI or AD, and red increased resting state in patient with MCI or AD. And so in this study, there was the study done by Helen Suo, where they wanted to see differences not just between Alzheimer's and healthy control. They wanted to see differences between different neurodegenerative disorder, Alzheimer's, frontotemporal dementia, and 3 other neurodegenerative disorder. And the point here was that in these studies, they showed that using resting state connectivity analysis, you had both specificity as well as sensitivity to differentiate not only between neurodegenerative disorders and healthy control, but also between Alzheimer's versus frontotemporal dementia versus semantic dementia, and so on. So it can be used to differentiate between different neurodegenerative disorders. This is showing differences between in ALFF and FALFF in AD subjects. Again, this is using different kinds of corrections to show differences between the 2 groups, right? We had covered REHO earlier, and REHO is a localized measure of connectivity, while other ones are on a voxel-wise measure. REHO is for every voxel, we see how correlated they are with a neighbor. And in this case, what we see is that AD patients showed a significantly increased REHO in the left frontal gyrus, right LG, right cuneus, and left cuneus. Also a decreased in the posterior, in the PCC was observed, right? And then this is using seed-based analysis. We observed that in the hippocampus, there was decreased connectivity, include the dorsal mediofrontal cortex, ACC, right cuneus, and other regions. So this is the difference. However, there was no significant decreased functional connectivity between left hippocampus and other regions of the whole brain. Since then, we have been looking at the correlation matrix. This is like the graph theoretical network where we take many different regions, a time series from different region, and correlate with every other regions. And using dynamic connectivity, we get a series of correlation measures. Then we use clustering to find a set of network, both from the white as well as gray network, gray matter network. And then by using network analysis, we can find different um, subregions which are connected, right? And this shows using graph theory that there is a difference between um, healthy control, MCI, and AD subject. So these are different network properties, and for many of them, so this is like deep white matter, somatomotor white matter, occipital, visual network. So among some of them, we see differences in network property associated with the corpus callosum. Again, as Dr. Shiv Kumar mentioned, there is, in addition to ADNI, there is another data set called the OASIS data set, which has 50 AD, 90 MCI, and about 100 healthy control. And we use graph theoretical analysis, as I described before, right? Using different region of interest, make this graph, look at their different properties, and then look at gray matter network, white matter network, and then see how they correlate with some of their basically gene ontology. And this is looking at healthy control versus MCI versus AD. And this is the t-test between, t-statistics between AD and healthy control, MCI and healthy control, like showing large changes here. And then by using functional connectivity with MMSE, which is a score which is used for, it's a very simple test used for AD, showing which regions there is correlation, right? So this is posterior limb of the internal capsule, right? This is like correlating with them and showing differences. And again, we are trying to look at the genes and then trying to look at these different measures of connectivity and see if we have, finally, again, using these kind of network properties like clustering coefficient, global efficiency, local efficiency, we can look at the differences in the distribution between AD versus healthy control, and basically see which, like, how is the distribution between different one. And the hope is that as we try to get more information, we can also use additional tests which can perhaps find more specific measures. And while just gray matter measures may not be enough, perhaps using in conjunction with white matter, we can find significant difference, which can help us better make prediction about Alzheimer's subject. I think that is all I have. Thank you so much.
Has this analysis reached the clinical stage or not yet?
Are these?
reach the clinical state in the sense that they can use this kind of thing to differentiate between AD and healthy controls and GI and other conditions or not yet?
Uh, so,
Are
yeah,
using this in the clinic?
so there are not many groups which are doing Alzheimer's study which are not part of ADNI. So we can do comparison between ADNI groups and show significance. But the challenge with that is the ADNI data is so well characterized in terms of the imaging parameters that it's almost like it's from the same data set. So the hope is maybe from Europe or so, if one could use a database and then test it, that would be a better indicator. Yes, also maybe the other one I think you alluded to is that the ADNI data also has longitudinal information. So many of these subjects have been scanned multiple times. And as Dr. Shivkumar mentioned, perhaps some of these analysis method could be used not just for detecting, but perhaps what would be even more important would be, can we predict the progression, right? Which subject who are in MCI will stay at MCI versus which subject will switch from MCI to AD, right? And while age is a big predictor, could there be other predictor like, do they have someone in their family who has Alzheimer's, or could there be some kind of intervention that could be used? Thank you. Right.
Should keep the parameters like ERD constant for both the populations, or it varies according to the physical population?
No, it must be kept same. Otherwise, it would create a like a different parameter. Like the images would look different between the two groups. And the not just that, maybe the signal to noise ratio that you would get in the fMRI signal would be different between the two groups.
So, but here we are assuming that clinical range, the state of clinical population will react similarly to those parameters as a normal state. So, this is based on that assumption. So, do we have any evidence that that these parameters may affect?
I understand what you're saying, but setting the same imaging parameters, I'm not. I can still assume that different subject will behave differently. It's just that um, the measurement technique that I'm using is the same across all subjects, right? So it would be